Now the next topic in the lecture is about WBCs. In that, we'll talk about leukocytosis. The first among leukocytosis is neutrophilia. An absolute neutrophil count, including both the poly and band cells, of more than 10,000 cells per microliter is considered as neutrophilia. The pathophysiology of neutrophilia involves increased production, increased marrow mobilization, or reduced margination. Margination is the adherence of cells to walls of blood vessels. Let's look at the causes of neutrophilia. The first and foremost is infection, especially bacterial infection. Peripheral smear usually shows more of immature cells, immature neutrophils. This is called as left shift. This happens due to increased recruitment of neutrophils to battle infections. Along with the leftward shift, we will also see toxic granules and Dolhe bodies. Second important cause is exercise and stress. Even burns can cause neutrophilia. Chronic inflammatory conditions such as gout, vasculitis, drugs such as glucocorticoids, epinephrine, lithium, cytokines, which are usually increased during an acute inflammatory event, and also administration of granulocyte colony stimulating factor can also cause neutrophilia. Myeloproliferative disorders, metabolic causes such as ketoacidosis, uremia, and other causes include malignancy, neoplasms, acute hemorrhage, or any other active inflammatory condition. What is leukemoid reaction? This is an extreme elevation of leukocyte count to more than 50,000 cells per microliter, usually composed of mature or immature neutrophils. Causes of a leukemoid reaction include infections, usually the severe infections and the chronic infections such as tuberculosis, especially in children. Other causes include hemolysis of severe nature, malignancies or neoplasms, especially carcinoma of breast, lungs, or kidney. Cytokines can also cause leukemoid reaction, including granulocyte colony stimulating factor. To differentiate leukemoid reaction from leukemia, leukocyte alkaline phosphatase is measured. This is elevated in case of leukemoid reaction and it is reduced in case of chronic myelocytic leukemia. Next, we are looking at leukoerythroblastic reaction. This is very similar to leukemoid reaction, except here there is an increase in nucleated RBCs plus schistocytes, or broken RBCs are seen in peripheral smear. So the causes of leukoerythroblastic reactions include myelophthisis, that is invasion of bone marrow by tumor or fibrosis, or granulomatous conditions, granulomatous conditions. And the peripheral smear classically shows teardrop cells or dacrocytes. Myelofibrosis also shows a similar pathophysiologic process, but here instead of any infiltration from outside, it is a primary disorder of the bone marrow itself where the fibrosis occurs from within. Another cause is hemolysis or hemorrhage, especially in severe cases. Lymphocytosis, an absolute lymphocyte count of more than 5,000 cells per microliter is considered as lymphocytosis. So the causes include infection, especially infectious mononucleosis, hepatitis, cytomegalovirus infection, rubella, pertussis, tuberculosis, brucellosis, syphilis, and other viral conditions, viral infections. Endocrine disorders where leukocytosis is seen include thyrotoxicosis, adrenal insufficiency, neoplastic conditions can also cause lymphocytosis. Examples include chronic lymphocytic leukemia, which is the most common cause of lymphocytosis, especially beyond 10,000 cells per microliter of absolute lymphocyte count. The next WBC is monocytosis. An absolute monocyte count of more than 800 per microliter is considered as monocytosis. The causes include infection, subacute bacterial endocarditis, tuberculosis, brucellosis, rickettsial infections, including Rocky Mountain spotted fever, malaria, leishmaniasis. Other conditions include granulomatous diseases such as sarcoidosis, Crohn's disease, collagen vascular diseases such as rheumatoid arthritis, systemic lupus erythematosus, polyarteritis nodosa, polymyositis, giant cell arteritis PMR complex, hematological conditions such as leukemias, lymphoma, and myeloproliferative disorders. Hemolytic anemia can also cause monocytosis, and malignant neoplasms can also elicit a monocytosis response. The next WBC component is eosinophil, and an increase of more than 500 cells per microliter of absolute eosinophil count is considered as eosinophilia. The causes are many, and these include drugs such as Dress syndrome, parasitic infections, allergic diseases, collagen vascular diseases, malignancies, and hypereosinophilic syndromes. Basophilia is considered when absolute basophil count increases to more than 100 cells per microliter, and the causes include allergic diseases, myeloproliferative disorders, especially CML. Chronic inflammatory disorders, which are exceedingly rare. Now let's look at the other end of the spectrum, leukopenia. This is taken into diagnosis when leukocyte count is less than 4,000 cells per microliter. Amongst them, the most important is neutropenia, and here the absolute neutrophil count should be less than 2,000 cells per microliter, and the chances of infections increases with the absolute neutrophil count less than 1,000 per microliter. So there are two ways neutropenia can occur. The first one is reduced production, and second one is increased destruction of neutrophils. So now let's look at the causes of neutropenia. First causes are drugs, the most common ones being chemotherapy medications for cancer. Other medications that can cause neutropenia include phenytoin, carbamazepine, indomethacin, chloramphenicol, penicillins, sulfonamides, cephalosporins, propylthiouracil, which is an anti-thyroid medication, phenothiazines, captopril, methyl dopa, procainamide, thiazides, cimetidine, allopurinol, colchicine, ethanol, and immunosuppressive agents. It is very important to know which drugs cause neutropenia, because avoiding them can reduce neutropenia occurrence and also reduce the infection of serious life-threatening bacterial infections. The second cause for neutropenia include infections. This is due to increased peripheral destruction of neutrophils for the most part, and these infections include viral, such as influenza, hepatitis, infectious mononucleosis, HIV, bacterial infections including typhoid, miliary TB, miliary tuberculosis, as well as fulminant sepsis. Malaria can also cause neutropenia. Now, the other causes of neutropenia include nutritional, such as B12 and folate deficiencies. Genetic causes include benign ethnic neutropenia, or BEN, which is seen in up to 25% of blacks. However, it is not associated with risk of infection. Another important genetic risk is inheritance of an allele of Duffy antigen receptor for cytokines, also known as DARC. This can also be associated with a neutropenia that is not associated with increased risk of infections. Other conditions include hematologic diseases, hematological conditions, cyclic neutropenia, aplastic anemia, bone marrow infiltration, Chediak Higashi syndrome, hypersplenism, such as Felty syndrome, congestive splenomegaly, Gaucher's disease can also cause neutropenia. Autoimmune conditions such as SLE, positive anti-neutrophil antibodies, can also cause neutropenia. The second one among leukopenias is lymphopenia. Lymphopenia is diagnosed when absolute lymphocyte count is less than 1000 per microliter. The causes include acute stressful events such as MI, pneumonia, sepsis. It can also be seen in glucocorticoid therapy. It can be seen in lymphomas, especially Hodgkin's lymphomas. Lymphopenia is also classically seen in certain immunodeficiency disorders such as ataxia, telangiectasia, Wiskott, Aldrich syndrome, and DiGeorge syndrome. It can occur in immunosuppressive therapy, which is usually given for lymphomas. Intestinal lymphangiectasias, that is increased lymphocyte loss, can also cause a lymphopenia. Chronic illnesses such as congestive cardiac failure and uremia, SLE, disseminated malignancies, and bone marrow failures, and miliary tuberculosis can also cause lymphopenia. The other two cells that can have penias include monocytopenia and eosinopenia. Monocytopenia is considered when absolute monocyte count is less than 100 per microliter. Eosinophil count, absolute eosinophil count of less than 50 cells per microliter is considered as eosinopenia. The causes of monocytopenia include acute stress illness, glucocorticoid therapy, aplastic anemia, leukemias, especially certain types like hairy cell leukemia, chemotherapeutic or immunosuppressive therapies. Similarly, eosinopenia is also seen in acute stress events as well as glucocorticoid therapies. So the next topic is bleeding disorders. Bleeding can happen because of three important abnormalities. The first one being abnormalities of platelets. Second one being abnormalities of blood vessels, especially blood vessel walls. Third one being abnormalities of coagulation cascade. Abnormalities of platelet produces petechiae, purpura, mucosal bleeds. Whereas abnormalities in the coagulation cascade can produce ecchymosis, severe mucosal bleeding, hematomas, and sometimes blood collection within the joint spaces called hemarthrosis. Now let's look at the first among these abnormalities, that is platelet disorders. The first disorder that we'll be looking at is thrombocytopenia. So the normal platelet count is 1.5 lakhs to 4 lakhs per microliter. Thrombocytopenia is usually defined as a number less than 1 lakh per microliter. So this is considered as thrombocytopenia. When the platelet count reaches less than 1 lakh, bleeding time increases. At this level of platelets, any surgeries or wound can have prolonged bleeding. At a platelet count of less than 20,000 per microliter, we may see spontaneous hemorrhages. At a platelet count of less than 10,000 per microliter, there are chances of serious or life-threatening hemorrhages. Just like with anemia, thrombocytopenia can happen because of two important reasons. One is increased platelet destruction, as seen in cases of ITP or TTP. The other cause being reduced platelet production, as seen with vitamin B12 deficiency or folate deficiency or bone marrow infiltrative disorders, etc. On bone marrow examination, increased platelet count destruction usually translate to increased megakaryocytes that are seen on bone marrow, whereas a reduced platelet production will obviously have a reduced megakaryocyte count on bone marrow examination. Let's look at the causes of each of these. The first one is production defects. These include marrow injury, which can happen due to radiation exposure or certain drugs. The second one is marrow failure, which can happen due to aplastic anemia. Third one is marrow invasion carcinoma, which can lead to metastasis within the bone marrow, leukemia, fibrosis. Other causes include sequestration of platelets, as seen in splenomegaly. The next cause is accelerated destruction. So accelerated destruction is usually seen due to drugs such as chemotherapeutic agents, thiazide, ethanol or alcohol, estrogens, sulfonamides, quinine, methyl dopa. Accelerated destruction include heparin-induced thrombocytopenia. This is usually seen in approximately 5% of patients receiving heparin for more than 5 days. This usually happens due to in vivo aggregation from anti-platelet factor 4 or anti-PF4 antibodies. Even though this is a thrombocytopenia, there is an increased risk of thrombosis, and arterial and venous thrombosis can be seen in such patients. Another important cause of accelerated destruction includes autoimmune mediated destruction. This can either be idiopathic, which is the majority of the cases, or it can be related to other rheumatological conditions or collagen vascular conditions such as SLE. It can also be related to lymphoma or even HIV. Another important cause is idiopathic thrombocytopenic purpura, commonly known as ITP. This ITP has two forms. The first one is acute form, which is usually self-limited, happens usually in childhood, and it does not require any specific therapy, so no specific treatment which is required. The second type is a chronic disorder which has a higher incidence in adult females, especially of the age 20 to 40 years, that is reproductive age group. This can be due to autoantibodies to either glycoprotein 2B3A or glycoprotein 1b9. Let's look at some more causes of accelerated destruction. Disseminated intravascular coagulation, or DIC. DIC constitutes platelet consumption and also consumption of coagulation factors. Hence, the other name for this is called consumption coagulopathy. Features classically seen in disseminated intravascular coagulation include prolonged prothrombin time, prolonged PT, prolonged APTT or activated partial thromboplastin time. There is stimulation of fibrinolysis, which results in increased generation of fibrin degradation products. One such example is D-dimer. Other features include a peripheral smear which shows microangiopathic hemolysis with classical schistocytes, or also known as helmet cells or helmet RBCs seen in peripheral smear. Now let's look at the causes for disseminated intravascular coagulation. Some of the important causes include infections, especially sepsis, which is defined as dysregulated host response towards an infection, a suspected or a proven infection. DIC is commonly seen with infections, especially of meningococcus, pneumococcus, gram-negative bacteria. Other causes of DIC include extensive burns or trauma, thrombosis, giant hemangiomas, a retained dead fetus, heat stroke, mismatched blood transfusion, metastatic carcinomas, and even acute promyelocytic leukemia. Let's move on to the other cause of accelerated destruction of platelets, and that is thrombotic, thrombocytopenic purpura, or TTP in short. So this is quite a rare disorder. It is characterized again by a microangiopathic hemolytic anemia. You can sort of think of small blood vessels filled with these fibrins or clots, and RBCs passing through these clots get broken easily, and that leads to hemolysis, which is exactly why we see helmet cells like this, or broken RBCs as we call it, or schistocytes on peripheral smears. So these are the broken RBCs. So they are seen in all of these microangiopathic hemolytic anemias. Apart from this, patient can also have fever and definitely thrombocytopenia, as the name suggests, a renal dysfunction, sometimes even hematuria will be seen in the patient, neurologic dysfunction. Let's look at the pathophysiology of TTP. This happens because of antibody formation towards a particular protease called ADAMTS13. This protease cleaves von Willebrand factors normally, and because of the antibody production, this protease is inhibited, and this leads to increased formation of von Willebrand factors and activation of von Willebrand factor. This leads to adherence of platelets and formation of these clots, as we see in this picture. Another common clinically relevant condition where thrombocytopenia is encountered is hemorrhage with massive blood transfusion, especially blood transfusion with only packed cells, as this clearly lack platelets, leading to a dilution and thrombocytopenia. Pseudothrombocytopenia. This is usually seen in collected samples, that is the samples collected within the test tube, especially when EDTA is used as an anticoagulant. On examination of the smears, it is easily found out that the platelet is clumped and multiple platelets are counted as a single platelet by the counting machine. So to prevent this, a citrate tube can be used, especially when a pseudothrombocytopenia is suspected. So instead of EDTA, citrate can be used as the preferred anticoagulant. Let's briefly touch upon the evaluation of thrombocytopenia. Platelet count of less than 1.5 lakhs per microliter, but a clinically significant thrombocytopenia is when the platelet count is less than 1 lakh per microliter. So first thing to be examined is to check for hemoglobin and total leukocyte count, or WBC count. So if the hemoglobin and WBC count are normal, that means that the patient is having only isolated thrombocytopenia. If it is abnormal, then that means the patient is having either bicytopenia or pancytopenia. In a normal total count as well as hemoglobin, evaluate with peripheral smear. This can have three outcomes. One, normal RBC morphology. Platelets are normal or increased in size. In such condition, think of drug-induced thrombocytopenia or infection-related or infection-induced thrombocytopenia or idiopathic thrombocytopenic purpura, or patient can have a congenital thrombocytopenia. The second outcome in the peripheral smear of a normal hemoglobin as well as normal white platelet count is fragmented RBCs. Fragmented RBCs, also known as helmet cells. This means that the patient is having a microangiopathic hemolytic anemia. So we have to either suspect DIC or TTP-HUS as the cause. The third outcome is patient has a pseudothrombocytopenia, which is evidenced by platelet clumping. So you can redraw the sample with either sodium citrate or heparin as the preferred anticoagulant. In the patient where there is abnormal or reduced hemoglobin as well as total leukocyte count, we will be looking at bicytopenia or pancytopenia. In such patients, we have to evaluate for reduced production of all three cell components. Here, you would want to evaluate for vitamin B12 levels or folate levels. Review the history and look for any medication which can cause bone marrow suppression, any drugs causing bone marrow suppression, or look for bone marrow examination to see for hypoplasia as well as infiltrative disorders. So the next subtopic under platelet disorders is thrombocytosis. As we know, the normal platelet count is 1.5 lakhs to 4 lakhs per microliter. Thrombocytosis, that is increase in the platelet count, is defined as any platelet count above 4 lakh per microliter. Thrombocytosis is usually classified as either primary or also known as essential thrombocytosis, or it can be secondary or also a reactive increase in the platelet count for several factors. Some of the causes for secondary or reactive thrombocytosis includes severe hemorrhage, an iron deficiency anemia, lymphomas, polycythemia, ovarian cancers, post-splenectomy, malignancies including Hodgkin's lymphoma. The thrombocytosis in malignancies is attributed to increased production of interleukin 6. Other conditions include chronic inflammatory conditions such as inflammatory bowel disease. Sometimes even vitamin B12 deficiency can cause thrombocytosis, or drugs which can cause thrombocytosis include vincristine, epinephrine. There is something called as rebound thrombocytosis, which can happen as the cytotoxic agents are removed or after replenishing with vitamin B12 medications or injections, or even after stoppage of alcohol. For primary thrombocytosis to become clinically significant, a platelet count should reach more than 1.5 million per microliter, whereas the secondary thrombocytosis does not cause any significant clinical effects. The effects of primary thrombocytosis can be two. It can be thrombosis owing to the increased platelet count, or it can also be bleeding manifestations, because even though the platelet count increases, the functional platelet count, the functional platelets or the platelets which work normally are very low. Now that we have understood thrombocytopenia and thrombocytosis, let's look at the disorders of platelet function. So the disorders of platelet function is usually suspected when the platelet count is normal. So the patient has a normal platelet count with an underlying increased bleeding time. Here the defect is usually attributed to defective platelet adhesion or aggregation or defective granule release. The causes for defective platelet function include drugs such as aspirin, non-steroidal anti-inflammatory drugs other than aspirin also, dipyridamole, clopidogrel, heparin, penicillins, especially carbenicillin, ticarcillin. Other causes of platelet dysfunction include uremia, cirrhosis, dysproteinemias, myeloproliferative and myelodysplastic syndrome, von Willebrand disease, cardiopulmonary bypass. Before we move further, let's revise coagulation cascade. So the coagulation cascade has an intrinsic and an extrinsic pathway. Intrinsic pathway is activated when there is an endothelial damage leading to exposure of collagen and kallikrein. This leads to activation of factor 12, which is also known as Hageman factor, into factor 12A. This factor 12A in turn activates factor 11 into factor 11A, along with calcium, or in the presence of calcium activates factor 9 into factor 9a. At this point, factor 8 is converted to factor 8a by thrombin. Factor 9a, factor 8a as well as calcium together activate factor 10a, that is converts factor 10 into factor 10a, and here the factor 5 is converted to factor 5a again by the action of thrombin. This activated factor 5a activated factor 10a along with calcium activate factor 2 into factor 2a. Factor 2a is thrombin. This activated factor 2a activates factor 1 into factor 1a, which is fibrin. Thrombin further activates factor 13 into factor 13a. Factor 13 is also known as stabilizing factor. Multiple fibrin threads in the presence of stabilizing factor as well as calcium forms a stable fibrin clot. This constitutes the intrinsic pathway. Extrinsic pathway is quite straightforward. Whenever there is a damage to endothelial tissue, directly activates factor 3 to factor 3a. Factor 3 is hence called tissue factor. Factor 7 is activated to factor 7a. Both of these factors combined in the presence of calcium activate the factor 10 into factor 10a and directly enter the common pathway. Hence, from the activation of factor 10, we call it common pathway. With this in mind, let's try to understand the coagulation disorders that are congenital. The first one is hemophilia A, which has a deficiency of factor 8, because of which the intrinsic pathway is affected. Wherever the intrinsic pathway is affected, the activated partial thromboplastin time is increased. Wherever the extrinsic pathway is affected, prothrombin time is increased. So in such patients where there is hemophilia A, the APTT is elevated, whereas the prothrombin time remains normal. In hemophilia B, factor 9 deficiency occurs, and because of that the factor 9 levels are affected. This again also leads to a similar condition like hemophilia A, where there is APTT which is prolonged, whereas prothrombin time which is normal. The third disease is von Willebrand disease, which also affects the factor 8 level indirectly. So this means that this patient also has a intrinsic pathway abnormality leading to an increased activated partial thromboplastin time, whereas the prothrombin time remains normal. Hemophilia C is an entity where factor 11 is affected, and because of that, because of the low factor 11, again intrinsic pathway is affected, and very similar to hemophilia A and B, here the APTT is elevated. We know that factor 2, factor 7, factor 9 and factor 10 are vitamin K dependent clotting factors. In case of a vitamin K deficiency, or when the patient is taking vitamin K antagonists such as warfarin, factor 2 is affected, factor 7 is affected, factor 9 is affected, as well as factor 10 is affected. As we can see, both intrinsic and extrinsic pathway are affected, and hence patient will have a prolongation of both APTT as well as prothrombin time. Let's jump into disorders of blood coagulation. The first one among this is congenital disorders, and the first subtype of this is hemophilia A. Hemophilia A has an incidence of 1 in 5,000 people. It's an X-linked recessive deficiency of factor 8. Here the factor 8 levels are reduced. The factor 8 activity, as we call it, is reduced, but factor 8 related antigen, that is von Willebrand factor, levels remain normal. As this affects only the intrinsic pathway, APTT is increased, whereas prothrombin time is normal. Second important condition is hemophilia B, also known as Christmas disease. This is due to the deficiency of factor 9. This has a slightly rarer incidence of 1 in 30,000 people. This is also an X-linked recessive disease. The clinical features are essentially same as seen with hemophilia A. Here patients usually present with hematomas and more commonly hemarthrosis. That is recurrent bleeding into joint spaces. The third congenital disorder of blood coagulation is von Willebrand disease. This is a common disease with a relatively higher incidence of 1 in 800 to 1 in 1000 population. Autosomal dominant and characterized by decreased levels or dysfunctional von Willebrand factor, which is a factor 8 related antigen. This leads to abnormal platelet function. Along with that, the factor 8 levels or factor 8 activity is also slightly suppressed, leading to an intrinsic pathway abnormality. Intrinsic pathway abnormality. So APTT is expected to be prolonged, and along with that, platelet dysfunction is also present. Let's now move on to the acquired disorders of blood coagulation. The first one among them is vitamin K. Vitamin K is a cofactor for carboxylation of glutamate residues on prothrombin complex proteins. Vitamin K dependent clotting factors including 2, 7, 9 and 10 are usually affected in case of vitamin K deficiency, and this leads to increased risk of bleeding. Since 2, 7, 9, 10 are involved in both intrinsic pathway plus extrinsic pathway, patient will have an increased activated partial thromboplastin time and increased prothrombin time. So the common sources of vitamin K include dietary sources, that is green leafy vegetables, and a small part of it is produced by the gut microbiota. Second acquired disorder that we are looking at is liver disease. Liver produces all the clotting factors except factor 8, and hence liver disease such as cirrhosis or even acute liver failure can lead to deficiency of all the clotting factors, leading to increased APTT and increased prothrombin time, and also increases the risk of bleeding. Other disorders or other causes of acquired coagulation disorders include disseminated intravascular coagulation, fibrinogen deficiency. This happens in liver disease, L-asparaginase therapy, rattlesnake bites, other causes include circulating anticoagulants, usually seen in lymphoma, systemic lupus erythematosus. It can also be idiopathic. Even massive transfusion can lead to dilutional coagulopathy.